to Dr. Deepa's Learning Launch. I am Dr. Deepa, and today I will discuss the practical approach for diagnosis of Barrett's esophagitis. So one of the most important premalignant conditions that we are taught is Barrett's esophagitis because it's a principal precursor lesion for esophageal adenocarcinoma. As pathologists, our diagnosis basically directly impacts the patient surveillance because whether you report it as non-dysplastic or you report it as indefinite, or if you report it as low grade or high grade, the cancer surveillance protocols changes according to your report. So it's very, very important that you know the classification well, that you will diagnose it perfectly, and you should be able to differentiate it from the mimics. So in the next 15 minutes, we will discuss the disease in detail. We will look at the WHO classification. We will look at the endoscopic assessments. We will look at the PREG classification. We will look at the important biopsy protocols. How many biopsies do we need to perfectly diagnose Barrett's? And we will also look at the 4-line concept, which many of you don't know. And we will look at the dysplasia gradings. And finally, the practical approach and tips for management. So by the end of the session, you should feel very confident in reporting Barrett's esophagitis and distinguishing it from a reactive ATPR and reporting Barrett's esophagitis according to the current WHO recommendations. So according to the WHO classification of tumor, what is Barrett's esophagitis? Barrett's, according to 5th edition, the definition says Barrett's esophagus is defined as the replacement of a normal stratified squamous epithelium in the distal esophagus by metaplastic columnar epithelium with intestinal differentiation. The routine pathology practice, the diagnosis generally requires the identification of a specialized intestinal metaplasia containing goblet cells because the intestinal metaplasia is the one that carries the greatest risk of progression into an adenocarcinoma. That is the reason why it is deliberately added to the definition. Barrett's esophagitis basically develops as an adaptive response to the chronic gastroesophageal reflux disease or GERD. And normally the esophagus, as you know, is lined by a non-keratinizing stratified squamous epithelium, which is suited for mechanical trauma. So whatever food that you're taking in, it to a certain extent produces mechanical trauma. That is why the esophagus is lined very well by non-keratinizing stratified squamous epithelium. But this stratified squamous epithelium is not equipped or to tolerate the recurrent exposure to gastric acids or bile. So when the reflux becomes a chronic event and there is repeated insults, repeated ulcerations, repeated repairs that are happening over and over again, this will ultimately lead to inflammation, ulceration, repair, and instead of this time the body, instead of regenerating a squamous mucosa which is not capable of handling the acid, the body tries to produce an intestinal metaplasia. It replaces the squamous lining with an acid resistant columnar epithelium. Initially the metaplastic change is actually a protective mechanism because the columnar epithelium tolerates the acid better, but it comes with a cost. The cost is that this becomes susceptible for accumulating molecular alterations in the later time, which ultimately leads to dysplasia, and dysplasia progresses into adenocarcinoma. So this is the pathogenesis. So this explains what I'm trying to tell you. And we know that Barrett's esophagitis is the only established precursor lesion for an esophageal adenocarcinoma. One of the most important points to remember is that Barrett's esophagitis is not a malignant condition. You have underlined that. Remember, not malignant. It is simply an intestinal metaplasia, as simple as that. The development of dysplasia is a separate event that occurs later on during its progression into a neoplastic event. So whether you diagnose Barrett's esophagitis today, ask yourself 2 important questions. First, is the intestinal metaplasia present or absent? First question. Second, is the dysplasia present or absent? There are 2 different questions which you have to answer in your report. When both of these answers are there, that is what determines the clinical management of the patient. So why do some patients having reflux develop Barrett's while others don't? There are some major risk factors that play a key role into that bias. Although GERD is the disease that is the major driving force for Barrett's, only a small proportion of patients actually develop Barrett's esophagus. Several additional risk factors play roles in this entire pathogenesis. So some of them include long-standing GERD, which I already told you, which is the major driving force. Next is the male sex. Usually male patients develop Barrett's esophagitis more than females do. The next is age above 50 years of age, central obesity, cigarette smoking, which is a common factor for any of the neoplastic lesions. White ethnicity is another risk factor. Family history of having an esophageal adenocarcinoma or Barrett's esophagitis is also a risk factor. So among these, chronic reflux disease and central obesity have the strongest association towards development of Barrett's. Let's now briefly understand the molecular alterations that are involved. Repeat exposure of distal esophagus to gastric acid and bile causes an epithelial injury, which we all spoke about. So once this epithelial injury happens, the next thing that has to happen is an inflammation, obviously. The inflammation, during inflammation, what happens? Interleukin 1 beta and interleukin 8 are the key inflammatories, they are the key to this inflammatory process, and they attract the inflammatory cells and they perpetuate the chronic mucosal injury. At the molecular level, the bile acids activate a transcription factor, particularly the CDX2, which is considered as the master regulator of intestinal differentiation. So after the activation of CDX2, this induces an expression of the intestinal genes, which is MUC2. Once the MUC2 is present, that is when the appearance of goblet cell happens in your tissue. As the Barrett's mucosa persists, the additional genetic abnormalities then start to be generated, which are molecular alterations of CDKN2A or P16, which is an inactivation. Then an abnormality of TP53 can occur that is strongly associated with progression of the dysplasia. So once these two are additionally there, the dysplasia is going to progress to high grade and then to adenocarcinoma. As the chromosomal instability increases and the dysplasia progresses, invasive adenocarcinoma sets in. Fortunately, this progression takes a long time, very fortunately for us. So it gives you a good chance for good surveillance and prevention. One of the biggest mistakes that is made by trainees here is to believe that Barrett's esophagus will become a cancer. Fortunately, that is not true. Only majority of the cases only remain the same. Minority of the cases, that too, which have missed careful surveillance, are the ones that actually go into adenocarcinoma. So now that we understood the Barrett's esophagitis, how it develops, the next is learning how the gastroenterologist assesses the extent of the endoscopy, because they will use that language when they're sending you a requisition. You should be able to understand what it means. So for this, uniform classification was brought up, which is called a Prague C and M classification, which is an essential understanding for all pathologists. So look at this image carefully. So when some gastroenterologist is doing an endoscopy, he might give you some C value and an M value. He might give you something like C3M7 or C4M5. So what does it mean? So basically, when you're looking at the Prague classification, the Prague C&M classification, it provides a standardized protocol method. So before this Prague's criteria was actually introduced, endoscopist descriptions used to be vague and confusing, because there used to be people who used to call it as a long segment. There used to be people who used to call it extensive. Some people used to just call it Barrett's present or absent on endoscopy. So that will not actually give you any clue about how far, how bad. And it is basically, it doesn't even give you a proper idea about the surveillance pattern. So that is why a uniform yardstick was introduced. So Prague classification solved the problem, and C stands for the circumferential extent. In the sense, it stands for the entire circumference of the tissue that is being looked at in endoscopy. M stands for the maximum extent. So these measurements are taken at the gastroesophageal junction. Very important. And it is not at the diaphragmatic kink. It is at the gastroesophageal junction. So the gastroesophageal junction is not the diaphragmatic hiatus. So when the patient has a hiatal hernia, the diaphragmatic impression lies distal to the gastroesophageal junction. So both of them should not be confused. You have to look at the place where the pink and the white are merging. That is the gastroesophageal junction. You have to look at that area and identify, and measurement has to be from that location. So let's look at the step-by-step thing that is done for Prague's classification. It is already labeled in the diagram. Take a look at the diagram. So step 1 is first identify the gastroesophageal junction on the top of the mucosal fold. If the hiatus hernia is present, distinguish the diaphragmatic hiatus from the GE junction and make sure you measure from the GE junction. Step 2, identify the circumferential Barrett's mucosa and measure the length of the Barrett's mucosa that completely encircles the esophagus. That becomes the C value. In the sense, if the circumference is measured, whether the entire whole circumference is there or is it only 3/4 the circumference, so that measurement is your C measurement. Next, identify till where the tongue-like measurements are going. Next identification that the endoscopist will do is that they look at how far is this tongue-like thing, and from the GE junction, how far is that tongue-like thing. That is the M, or the maximal extent. In general, the M value is equal or greater than the C value. So most likely, M value should be a bigger number than the C value. Suppose the circumference of the Barrett's esophagitis extent is 3 centimeters. and the area where the tip of the tongue is on those tongue-like projections is somewhere around 8 centimeters, then the break classification should be reported as C3M8. Okay, that is a simple notation. And Barrett's esophagitis should be diagnosed when there is an extension of the salmon-colored mucosa into the tubular esophagus extending greater than 1 centimeter proximal to the gastroesophageal junction by rule. And the confirmation is strongly recommended. If there is any low lesion, then confirmation has to be done. And endoscopic biopsy should not be performed if the presence of a normal Z line is present, or if it is less than 1 centimeter or variability, then you should not perform the biopsy at all. In presence of Barrett's esophagitis, the endoscopist should describe the extent of the metaplastic change, including the circumferential and the maximum extent, by using the classification and send it out for biopsies. So if the patient has suspected Barrett's esophagus, then the endoscopist has to have at least 8 random biopsies, not 1 or 2. 8 random biopsies should be obtained to maximize the yield on the histology. If the patient has a short, let's say 1.5 to 2 centimeters, very early that you picked up, then if you think 8 biopsies are not possible, then at least 4 biopsies have to be sent. That is a rule. And if the patients have a Barrett's esophagitis suspected and lack any of the changes in histology, a repeat endoscopy is recommended at an interval of 1 to 2 years' time to rule out Barrett's again. So that is a main surveillance point. In case your biopsy let's say it's a small lesion that would roughly say 1.8 centimeters, and then they've given you 4 biopsies because they can't take 8. And all the 4 biopsies have no features, no intestinal metaplasia on your biopsy. Let's say it has columnar change, but not goblet cells. Some scenario like that. That is also something that you do see. So in some scenario like that, the surveillance has to be repeated. The biopsy has to be repeated at an interval of 1 to 2 years. That is very important. Then the diagnosis of Barrett's esophagus. What is Seattle biopsy protocol? More important is detection of the dysplasia here, right? So it depends only on adequate biopsy sampling. And the dysplasia is usually patchy. Unfortunately, it's patchy. So whenever the biopsy is taken, that is the reason why you have multiple biopsies put in the criteria, so that you don't miss a patch. And yes, clinically also, they would pick up the more pinkish area. So if 1 or 2 biopsies are taken and you see significant dysplasia, you see that significant dysplasia in this condition can be easily missed. So that's the reason why Seattle protocol was brought about, which remains a gold standard for biopsy taking for Barrett's esophagitis. The protocol is very simple. Visible lesion should always be biopsied. That's the first rule. It has to be resected first. In the sense, if there is big, large pink tongue that's coming up the G junction, take the biopsy there for sure. Obtain 4 quadrant biopsies every 2 centimeters throughout the Barrett segment. 2 centimeter, 2 centimeter, 2 centimeter, 2 centimeter, at least 4. If the dysplasia is already known or strongly suspected, then the sampling density should be every 1 centimeter, according to the Seattle protocol. So this systematic approach improves the chance of dysplasia detection. And another important thing is its orientation. A poorly oriented biopsy will make the assessment of dysplasia very, very difficult. So the orientation has to be very, very good. There should be a very good communication between the endoscopist and the pathology laboratory for sure. So never miss taking ample biopsies for Barrett's. And if it's a poorly sampled type of a biopsy which lacks orientation, which is crushed or artifactual, don't report. Ask them a repeat biopsy very clearly. So let's look at what the endoscopy actually looks at now. So when you look, this is the Barrett's, which is negative for dysplasia. As you see, there is a columnar change, but it is negative for dysplasia. There are goblet cells also. You're seeing these small mucin, like these opening type of thing, so that in the low microscopy itself, you are able to make out that those are goblet cells. So first image is negative for dysplasia, the image A. So in Barrett's esophagitis, the negative for dysplasia means that the epithelial changes are reactive and non-neoplastic. The surface epithelium demonstrates a normal type of a maturation. The cells here are showing nearly the normal size, right? The cells here are showing nearly the normal size. And if you see, they are aligned more or less in a uniform way. There is no stratification of the nuclei here, even at this power. There are nuclear membranes are showing roughly a uniform kind of appearance. So you don't see much of an activity there. And there is no mild ATP also. It looks absolutely fine. Okay, but you can still call it negative for dysplasia even if there is very mild kind of an atypia in the basal regions, which is common in Barrett's. don't report it as low grade. If you have some small basal atypia here and there, you should still call it negative for dysplasia. If the NC ratio is normal, low nuclear cytoplasmic ratio is seen, no stratification, not much atypia, call it negative. And there should not be any hyperchromasia anywhere. There should be no pleomorphism, and architectural distortion should be definitely absent for you to call negative for dysplasia. Remember that for sure. Although the risk of progression in this negative for dysplasia is relatively low, which is about 0.12 to 0.5%, it remains substantially higher than the general population. So you have to remember that once Barrett's sets in, they're no longer normal people, right? So they still have some change. So surveillance is definitely important. So when you give negative for dysplasia, the endoscopic surveillance timing is 3 to 5 years. Within 3 to 5 years, they have to repeat the whole process. You have to again look at the biopsy. You have to again report it. All right. So next is the B. What we are seeing is B. So in the image B, if you look at the image B here, just you compare it with A. This is looking a little more blue. The nuclei are looking a little more blue, right? So even at lower power, you are able to make out a difference. So low-grade dysplasia is the image B that you're seeing. Basically, low-grade dysplasia is the earliest unequivocal neoplastic condition in Barrett's esophagus. Cytologically, the nuclei are slightly bigger than the counterpart on your left. If you're seeing on the left, these nuclei are slightly bigger. That's why you're seeing it as more blue. They're slightly enlarged, slightly elongated, slightly hypochromatic, slightly stratified. Atypical cells, 1 or 2 may be present, extending to the epithelial surface. A distinct transition between non-dysplastic and dysplastic mucosa may also become evident in some of your biopsies if they have both the areas. But you have to remember that in low-grade dysplasia, nuclear polarity is definitely maintained. There is no lack of polarity. Architecturally, the glands usually retain their normal configuration without the complex patterns such as cribriforming. And there is no severe pleomorphism in this case. So only the nuclei look a little more elongated. There is some amount of stratification. And you have to make sure that although they are there, some atypical cells are there here and there, nuclear polarity is largely maintained in low-grade dysplasia. And these glands retain their normal configuration. There is no cribriforming. There is no severe pleomorphism. There is no architectural complexity. That is when you call it low-grade dysplasia. And yes, there is some amount of inter-observer variability that is present at this particular entity. But however, annual surveillance is very important in this case. Annual surveillance is 0.5 to roughly about 0.5 to 1.4% of the cases may undergo annual progression towards adenocarcinoma. And if the timely intervention is deferred, annual endoscopic surveillance is definitely recommended for it. In the sense, last time I told you in the last particular lesion, I told you once in 3 to 5 years is what they have to check for no dysplasia. But for this particular condition, you have to have an annual kind of a surveillance, right? So when you have low-grade dysplasia, surveillance has to be once in a year. So there's a marked difference in the surveillance interval depending on the report that you're giving out, right? Now let's carefully look at the C image. What you're seeing here, more stratification clearly. So more nuclear pleomorphism clearly, isn't it? Even at this power, you can very clearly see. So here, this is a high-grade dysplasia that I'm showing you in MHC. The high-grade dysplasia exhibits both cytological atypia and significant architectural abnormality. So that is the architectural abnormality is the basic difference between the low-grade and the high-grade. But the basement membrane is intact, even in high-grade dysplasia, that is never breached. All right. So the characteristic cytological finding is enlarged, pleomorphic, hyperchromatic, stratified type of nucleus with increased nuclear cytoplasmic ratio, irregular nuclear contours, and there may be prominent nucleoli also here and there in this architecture. But there also is cribriforming. There also is cribriforming in some areas. So basically there is gland crowding also. There may be papillary or villiform architecture here and there. Basement membrane is not breached. That is when you call it a high-grade dysplasia. Okay. High-grade dysplasia carries a significant risk to progression towards invasive adenocarcinoma, estimated to be up to 6% per year. Consequently, the endoscopic eradication therapy is recommended at this stage itself. Okay. Then is indefinite for dysplasia. That's an entity that is there in WHO. Indefinite for dysplasia is when your diagnostic, it's a diagnostic category which Should not be used just like that. You have to use this diagnostic category when the epithelial changes are raising a concern for dysplasia, but are not giving you a confirmation of a definitive diagnosis. Don't use it as a waste paper basket because it will directly impact the surveillance of the patient. So suppose there is some amount of active inflammation and ulceration in the patient, and suppose there is reactive atypia, which closely mimics a dysplastic change. Let's say the histological epithelium is showing abnormalities or mild architectural change, but the findings cannot be distinguished whether it is inflammatory or dysplastic. There is some midway entity that you're not able to really find out if it is reactive atypia or it is dysplastic. That is when you will use this particular indefinite for dysplasia. That is a category that is indefinite for dysplasia is what I'm showing you here on the image 4. This image 4 is indefinite. You are able to see there is some mild stratification here and there, prominent inflammation, some amount of ulcerations here and there, but you're not very confident that it is dysplastic, correct? Some cribriforming is also there. Can't really say if it is inflammatory or dysplastic. That is when you do this one. That is when you use indefinite for dysplasia, but don't use it as a waste paper basket. Patients with this indefinite for dysplasia have an annual progression rate of 0.85 to 1.4. Again, all of this is also based, also very important is that your endoscopist should give you ample sampling. Don't talk about the diagnosis, whether it is indefinite or definite, unless you have ample sampling. Okay. So since the progression is much lesser, the endoscopic surveillance for diagnostic agreement among pathologists is relatively poor in this particular entity. But standard management involves optimizing the proton pump inhibitor therapy for 3 to 6 months, followed by repeat biopsy for a better histological assessment after a time period of 6 months repeated for indefinite. Okay, because that is not a waste paper basket. You just don't know if it is actually active inflammation or dysplasia. So surveillance after proton pump therapy is recommended. So these are the 4 categories in which Barrett's esophagitis has to be reported. I hope I'm very clear. So I've put the same thing in a table. So negative for dysplasia, there is no nuclear atypia, absent or mild reactive nuclear atypia. Surface maturation is preserved in negative for dysplasia. Nuclear polarity is preserved. Architecture is normal. Annual cancer progression 0.1 to 0.5, which I just told you. And surveillance is once in every 3 to 5 years. If it is indefinite for dysplasia, it's not a waste paper basket. You have to use it very carefully. Then nuclear atypia is more or less equivocal. You can't really make out if it is inflammatory or dysplastic in this particular variant. And then surface maturation is variable. Then nuclear polarity is usually preserved. Mild distortion of architecture will be present. Then the annual progression in this particular thing is 0.84 to 1.4. PPI therapy followed by repeat biopsy is its recommended management. Low-grade dysplasia, there is a definite mild to moderate nuclear atypia. There is surface maturation which is lost. There is nuclear polarity is preserved here very clearly. Architecture and nuclear polarity is preserved. Very, very important for low-grade dysplasia. Annual progression is 0.5 to 1.4%. Endoscopic eradication therapy and annual surveillance is something that you do once in a year. Annual surveillance. Annual surveillance means once in a year you have to check. High-grade dysplasia, marked nuclear atypia, surface maturation lost, nuclear polarity is lost, complex architecture, cribriforming papillary or villus pattern. Then in this annual cancer progression, if you see, you had less than 2% in all of these entities till now. This is almost 6%. High-grade dysplasia is giving you an annual progression rate of almost 6%. In the sense, if you have sampled 100 patients, 6 of them are definitely going to go into adenocarcinoma. So you have to have an endoscopic eradication therapy in high-grade dysplasia for sure. And then a repeat biopsy after healing, right? So that is your entire feature of each of the Barrett's esophagitis, that diagnosis and the variants. So one important thing is you should know the differential diagnosis also. The most important pitfall in Barrett's esophagitis is a gastric cardia-type mucosa. God save you if the biopsy is taken in the wrong area. Then one important thing is the cardia-type mucosa contains mucus-secreting columnar cells, but they lack the true goblet cells. That is very important for you. So morphologically, when you're assessing it, this is also the cardia-type of esophagus, the gastric cardiac mucosa. So when you're looking at this, they lack goblet cells. They have mucus cells. So without goblet cells, the diagnosis of Barrett's esophagitis should not be made, and it should be made very consciously. So the clinical significance is, why is goblet cells very important? Because intestinal metaplasia is the only thing that is the precursor for adenocarcinoma. So goblet cells are required to make the diagnosis. So never confuse an intestinal metaplasia and dysplasia. They are entirely different. Okay. So now let's look at the case that I showed you. So this was a whole slide image that I showed you. You're able to very clearly see here that there is so immense nuclear stratification. There's cribriforming here and there. There's so much of nuclear stratification. And the basement membrane, however, is good. So much of nuclear stratification. There's lack of polarity. Goblet cells are definitely there. So this is a high-grade dysplasia in Barrett's esophagitis. This was a case that I shared with you. Okay. So now that we identified Barrett's esophagitis and we looked at what microscopically are the different types of Barrett's and what are the dysplasia that you have to report out. Now the challenge is distinguishing a reactive atypia from the actual dysplasia of Barrett's. So one concept that is not there in the WHO but is practically very useful is the 4-line concept, which we will discuss. So the 4-line concept basically is line 1 is the gastric mucosal vacuole here. And line 2 is the base of the vacuole. Line 3 is the cytoplasm. Line 4 is the nucleus. So you draw 4 lines. They should be parallel. Okay. These 4 lines have to be identified. That is the 4-line concept. So that is a very useful concept to differentiate between a reactive atypia and a dysplasia. All right. So the distinction is, let's see each of these 4 lines line by line. The line 1 I told you is apical mucin cap. The line 2 is the base of the mucin vacuole. The line 3 is the cytoplasm of the vacuole, cytoplasmic zone. And the line 4 is the aligned nuclei. So what happens in reactive atypia? When the reactive inflammatory changes happen, the nuclei may become enlarged, hyperchromatic, slightly irregular. And at first glance, it may mimic the dysplasia. But when you carefully examine the surface epithelium, the overall porality is very much preserved in the sense that these 4 horizontal lines remain intact, like the one picture that I'm showing you. 1, 2, 3, 4. These 4 lines are intact. This is not dysplastic. This is just reactive. So the preserved 4 lines strongly support reactive atypia rather than dysplasia. Very, very important concept. So what happens in case of dysplasia then? When dysplasia develops, the normal epithelial organization tends to break up. So what happens is the cytoplasmic zone may narrow or diminish or disappear completely. You will just see the mucin followed by the nucleus directly. The rest of the lines are not there. So any of these 4 neat horizontal lines, if you're not able to identify, it is more likely dysplastic than reactive. A very important tip, very practical. I have tried it in multiple samples. It works like magic. I would recommend anybody to use this. It's a 4-line concept. So basically, it can be applied when the biopsy is poorly. One thing is there are some limitations. The biopsy sample has to be clearly, neatly oriented for you to apply these 4 lines. There are some limitations to usage of these 4 lines. So it has to be applied only when the biopsy is perfect. When there is surface, you cannot apply it when the surface epithelium is cut off. You cannot apply it when the orientation is not right. And you cannot apply it when there is erosion or ulceration, active erosion or ulceration. You cannot apply this. Okay. So as a teaching goal, remember, if the 4-line concept, 4 lines are present, preserve polarity, reactive process. 4 lines lost, loss of polarity, dysplastic. Clear? So this is an important concept for you to suddenly look at this. So this is a low-grade dysplasia of Barrett's. I wanted to show you a contrast with low-grade dysplasia also. There is mild stratification, but it is still okay. Okay. So now we look at, once the Barrett's esophagitis has been diagnosed, the next step is of the pathologist is to determine whether the dysplasia is present. I told you already. So the different groups, I just wanted to repeat myself on this. So the different groups is negative for dysplasia, indefinite for dysplasia, low grade, high grade. Negative for dysplasia is when there is a non-diagnostic, it is a non-dysplastic Barrett's esophagitis in which the epithelium shows intestinal metaplasia with goblet cells. You may see some mild nuclear enlargement. The basal portions of the gland may show some mild atypia sometimes. But surface epithelium is absolutely normal. Nuclei remain basally located and glandular architecture is completely preserved. Then call it no dysplasia. Indefinite for dysplasia is a category where it is a very simple diagnostic category where there is inflammation, ulceration, regenerative atypia, but you cannot confidently delineate whether it is dysplastic or reactive. That is when you put IND, indefinite for dysplasia. Low-grade dysplasia is when elongated hyperchromatic nuclei may be present. Nuclear cytoplasmic ratio may be slightly increased. There may be slight nuclear stratification, but the nuclear polarity is maintained and the architecture is maintained. Then call it low-grade. When it is high-grade dysplasia, that demonstrates a severe abnormality where there is nuclear pleomorphism, enlarged vesicular nuclei, nuclear polarity is increased, full thickness nuclear stratification is present, frequent mitotic figures are present, glandular crowding is seen, cribriform architecture also may be seen. Then you call it high grade. So far we discussed the diagnostic and grading. So as a final section, we will look at molecular pathology, practical reporting, and current management, and the key takeaway message. Okay. So when we are looking at the morphological diagnosis of Barrett's, we have to look at the molecular changes also, which I already alluded to, which is initially it will be the CDKN2A or P16 variation, then TP53. In recent years, P53 immunohistochemistry has emerged as an adjunct to your diagnosis. So normally P53 shows weak or scattered nuclear staining. An abnormal staining pattern, either when it is diffuse or strong overexpression or a complete absence or a null pattern. These are the things that suggest that TP53 mutation has occurred. That supports the diagnosis of dysplasia, and that is interpreted alongside the diagnosis morphologically. So it is important that P53 is an adjunct and not a substitute to morphology. Your morphology comes first. But all said and done, perfect biopsy has to be there with perfect orientation for you to diagnose. Another exciting development is artificial intelligence in digital pathology, where AI is now being used to identify Barrett's much better than the inter-observer variability is also much less. So there are commercial tissue-based risk stratification platforms such as TissueCypher. There is a new thing that combines the morphology, biomarkers, and it is a machine learning platform that has good credibility in predicting a high-grade dysplasia and adenocarcinoma. So remember the sequence in general. P53, P16 alteration is an early event. TP53 abnormality is progression towards dysplasia. Chromosomal instability means adenocarcinoma. Okay. So next, if we look at the practical reporting and management, early Barrett's biopsy report should answer a few essential questions. So first, confirm whether there is intestinal metaplasia or no, and determine whether the dysplasia is present or no. Then divide it into the WHO classifications, which you know, which is negative, indefinite, low grade, high grade. And if the suspicion of an intestinal carcinoma is there, then it should be clearly stated in your report. That is also very important. While diagnosing low-grade dysplasias, remember that high degree of inter-observer variability may be present. So current diagnosis recommends the confirmation by an experienced gastrointestinal pathologist before major therapeutic decisions are made. And patients with non-dysplastic Barrett's esophagitis should undergo periodic endoscopic surveillance, which is between 3 to 5 years. Patients with indefinite should again repeat biopsy after a PPI therapy. Patients with low grade have to have annual surveillance. Patients with high grade should have endoscopic mucosal resection or radiofrequency ablation immediately. Selected deeper lesions may be required for submucous dissection also has to be done in cases of high grade dysplasia. Okay. Then practical reporting checklist that you have to have. One is have a mental checklist. Are there goblet cells or no? Is there dysplasia or no? What is the grade of dysplasia? And if there is a grade, is P53 IHC needed in the case or no? And this, once you review this way, you are a good GI pathologist. So before we conclude, let's summarize the important points. Take a screenshot of this. I have prepared this for you guys. So first, there are 6 key messages in my entire talk. First, Barrett's esophagitis is a replacement of the distal esophageal squamous epithelium by intestinal type columnar epithelium as a consequence of chronic GERD. Second, diagnosis depends on the identification of the specialized intestinal metaplastic goblet cells in conjunction with appropriate endoscopic findings. Third, endoscopic assessment should be standardized. Use only PREG-CNM classification. Surveillance biopsies have to be used on the basis of Seattle biopsy protocol. Fourth, use the 4-line concept whenever you are in doubt between dysplasia versus reactive atypia. Fifth, WHO recognizes 4 distinct categories, which is negative, indefinite, low grade, high grade. Remember that indefinite for dysplasia is a diagnostic category, but not a biological stage for progression. Finally, accurate pathological interpretation directly prevents esophageal adenocarcinoma. So as a pathologist, we play the vital role in interrupting the metaplasia, dysplasia, carcinoma sequence here. So thank you for your attention. I'd be happy if you can post any comments if you want me to further explain this topic in detail or any other topic that you want. So this is Dr. Deepa signing off today. I hope you like my lecture on Barrett's esophagitis. Bye-bye.